we'll go ahead and jump in. Yeah, I will say one thing. If I'm a little stiff, 5 weeks ago today, I had 5.5 hours of back surgery. So I'm kind of happy to be standing and walking around right now. So I'm actually doing great considering all they did. Let's talk about ADHD. I just have 30 minutes, so I'm going to kind of fly through this pretty quickly. I usually give longer workshops, but this was one that I was able to, since I'm presenting to healthcare providers, I thought I'd try to get focused on the things that'd be most relevant to you. So let's talk about this. What is ADHD? It's Attention Deficit Hyperactivity Disorder. I tell parents it's a biological, neurological, mostly genetic condition that people are born with, they live with, and they die with it. There is no cure for it. It is something that people will live with all of their lives. They will be born with it and they will go to the grave with it. It is not caused by inadequate parenting. It is primarily genetic, although bad parenting can make it worse. It doesn't cause it. And for the vast majority of people, ADHD will continue on to adulthood. Now, some statistics on it is about 4.5 to 5.5% of all children are said to have ADHD, and about 3.5 to 4.5% of all adults are said to have ADHD. Now, my thinking is that adult percentage has gone up in the years because we've gotten better at detecting it, and I think ultimately they're going to be about equal. I think a lot of times ADD will get better when you get into adulthood and people will adjust and adapt, and it doesn't look so obvious, but I think it doesn't go away. We know statistically that about 9.5% of U.S. children, according to the CDC, or 6.4 million children in the U.S., are diagnosed with ADHD. And we also know that 40 to 60% of all individuals are undiagnosed. People talk about it being overdiagnosed. Well, the CDC would differ with you and tell you that it's underdiagnosed. Male to female, this is interesting. Over the years, the ratio has gone down. We used to say 8 to 1, 8 males to every 1 female. Then the research said 6 to 1, and then 4 to 1. Now they're saying 2.4 to 1. So the instances of females with ADHD are more and more these days. We know also that as I said earlier, it's highly genetic. Here's another little piece of research that I think is fascinating. When I was at Emory as an undergraduate, I was taught that the concordance rate for identical twins, in other words, if one twin has it, the other twin is likely to have it, that the highest concordance rate of all mental health was schizophrenia. And it had a 50% concordance rate. So if one identical twin had schizophrenia, there's a 50% chance the other would have schizophrenia. Okay? And when I was in graduate school, taught the same thing. And for years, for decades, that's what we taught, that the highest concordance rate was 50% for schizophrenia. Well, guess what the concordance rate is for identical twins with ADHD? 81%. That blows the socks off number 2. Which is schizophrenia. I think that's amazing. Here's another little statistic. Children who have ADHD their parents are 3 times more likely to separate or divorce than children who don't have ADHD. Teenagers have almost 4 times as many traffic citations as their non-ADHD peers. Teens who have ADHD have 4 times as many car wrecks and 7 times more likely to have a second accident. And fatalities with children and adults who have ADHD are higher than those people who do not have ADHD. I'm going to skip the diagnostic criteria because I'm assuming y'all can take a look at that in DSM. What causes ADHD? Well, there's a lot of research that says it's underactivity of the frontal lobes. And there's a lot of research for decades. There have been dozens and dozens of research studies where they've compared the brains of people who have ADHD with control group of people who do not have ADHD. And sure enough, the brains are fundamentally different with people who have ADHD versus those that don't. These are the MRI and CAT scan studies. And what we find is that the frontal lobe and the frontal lobes are underactivated. The frontal lobes have reduced blood flow, and the frontal lobes are smaller in people who have ADHD. So, when you think of the frontal lobes, what do you think of besides attention? Executive functions, okay? And so there's a lot of research out, and Russell Barkley, what I tell people is Russell Barkley is to ADHD what Einstein is to physics. He's just the top researcher in the world on ADHD. And he and Thomas Brown, who's up at Yale, I believe, have both proposed that we change the name of ADHD to executive function disorder. Because they say that the three hallmark signs and symptoms of ADHD are inattention, impulsivity, and hyperactivity. Okay, two of those three, the inattention and the hyperactivity, the inattention and the impulse control, are what we call executive functions. But there's more executive functions than just those two. Other executive functions include organization, initiation, problem solving, taking feedback from your environment, and then adapting and changing based on the feedback, and then following through to completion. Okay, all of those are the executive functions. Okay, and what Barkley and Thomas Brown are suggesting is that we change the name in DSM-6 to executive function disorder or executive function deficit disorder. So we will see. Now we're talking about the fourth cardinal signs and symptoms of ADHD, inattention, hyperactivity, and impulsivity. We're talking the fourth one as being a disorder of executive functioning. Okay, the most common definition of executive function is those mental abilities needed to sustain problem solving toward a goal. So the ability to come up with the goal and do the problem solving so that you obtain that goal. Barkley talks about the 30% rule, and the 30% rule is that on average, a person with ADHD has a deficit of their executive functioning by 30%. Okay, and so what he means by that is if you have a 9-year-old, their executive function is equal to that of a 6-year-old. And I have a great slide here I wish y'all could see, but I just put the ages down. So here are the ages there, and the first number is going to be a ratio. The first number is going to be the age, the second number will be the level of executive functioning. So when you're 6, you're functioning at a 4-year level. When you're 10, you're functioning at a 7-year level. When you're 20, you're functioning at a 14-year level. And when you're 28, you're functioning at a 19-year-old level. Now we know that the executive functions continue to develop until mid to late 20s. So being generous, let's say it continues to develop until you're 28 years old. Okay? Does that mean that your executive functioning will stay around the equivalent of a 19-year-old when you're 40, 50, 60, 70, where your executive function would be about a 19-year-old? Well, the research suggests yes. That's the case for people who have ADHD. Kind of maxes out when they're in their late 20s, and the executive function maxes out to be equivalent to someone that's 19. Now, if that's average, this is what I have on here too. I wish y'all could see this. It's so cool. So here's my pondering. If average is 30%, is mild ADHD 10 to 20%? And is severe ADHD 40 to 50%? Makes sense to me, okay? There was a minister who said something that I thought was really great. He asked the question, what is the wise thing to do? And this was his definition. He said, in light of my past experience, current circumstances, and future hopes and dreams, What is the wise thing for me to do? So wisdom is considering past, present, and future. Well, Berkeley has conceptualized ADHD in a new way, and what he calls it, which I think is really interesting, is time blindness. That people who have ADHD are blind to time. And what I have called, for a year or two I gave credit to Berkeley, but then I reread everything I could in Berkeley and I couldn't find it, so I'm taking credit for it. It's called prisoner of the now. That a lot of people who have ADHD are prisoners of the now. Now is all that matters. Don't think about the past, don't think about the future. It's now is what happens. So other terms that Berkeley has used is an altered sense of time, nearsightedness to the future, blind to time or the future, future neglect syndrome, a disorder of future-directed behavior. And I like this one, temporal myopia, or time blindness. And Berkeley notes that without a sense of future, it's hard to defer gratification. So there's where a lot of the impulsivity comes from. Okay, comorbidity. We know that by the time an individual is 18 years old, there's an 85% chance that they will have at least one other mental health diagnosis. And more than likely, in other words, greater than 50% chance, they'll have at least 3 mental health diagnoses. So we very, very, very rarely see ADHD by itself. It's just pretty rare. We know that oppositional defiant disorder occurs about 50% of the time. Conduct disorder about 15% of the time. Anxiety disorders about 30 to 40% of the time. Depression about 33% of the time. We know that the highest risk of suicide is someone who has depression plus ADHD plus either oppositional defiant disorder or conduct disorder. That for teenagers and young adults, that's the number one person who's likely to commit suicide. Learning disability, there's about a 40% concurrence rate. People with tic disorders very often have ADHD. Not necessarily the other way around, but if you look at it one direction, if you have OCD, there's a higher percentage likelihood that you'll have ADHD. Same with tics. Just because you have ADHD doesn't mean you're going to have tics. But if you have a tic, high likelihood you will have ADHD. And autism, same thing. Just because you have ADHD doesn't mean you're more likely to have autism, but if you have autism, you're more likely to have ADHD. Okay, does that make sense? So some of these are like unidirectional, but still significant. Let me talk about a 5-part assessment of ADHD. And this is where you really got to see the slides. I wish y'all could see that because these are really cool. Okay, when I look at ADHD, I mean, I'm a psychologist. I like testing. I do a lot of assessments, okay? I have a 5-part assessment that looks at it. One is I have some short-term measures of attention and concentration. These are a minute or two, but I have 5 of them. The second thing, I have 2 tests called continuous performance test. Okay, and a continuous performance test means you have to continuously perform. It's like driving down I-75. If you're driving down I-75, you got to stay focused the whole time. You can't take a 2-minute break as you enjoy the scenery. You've got to stay focused, okay? So we think of that as sustained attention. And the continuous performance test or computerized test, where it starts and it goes on, and you're either focused and doing it or you're not. Okay, so the test is going to go on whether you're focused or you're not. Rating scales for ADHD and executive functioning is the third. The fourth is, of course, clinical interviews, and I like to interview the patient and collaterals. Of course, the best collateral for a child is the parents. And then to take a look at the developmental, medical, and family history. Somebody that's what we do is we say, circle the letter A. And I have my doctoral student sit behind them, and she'll have a piece of paper with them already circled, all the letters A that are circled. And she'll track the person doing it. And when we have somebody that's not ADHD, we see a pattern that's kind of back and forth, or up and down. You see how that, can y'all see over there how that works? But not somebody who has ADHD. What we get is just a blast of disorganization. It's like they're all over the place. And it's disorganized. It takes them twice as long. There's just no rhyme or reason. It looks like a pinball just going everywhere. That's pretty clear. And I use this test, a lot of it is just to show parents. Here's someone that is ADHD. And you see they're just kind of all over the place. Just very unorganized. Okay, so planning, organization, forethought. These are part of the executive functions that are impaired in a major way with people who have ADHD. Now, another test I use, which I love, and I'm going to show you all this one too, instead of showing you all three, I'm going to just show you the final one. Okay? It's called the TOVA, the Test of Variables of Attention. And on the TOVA, it's got a computer screen, and it's blank, and a box will pop up there and then go away. And the only difference is sometimes there'll be a little black box up on the top, and sometimes there'll be a little black box down on the bottom. And it's random. There's no rhyme or reason to if it would be up top or if it would be down on the bottom. And they have a wire with a button on it, and they're instructed to pay attention. And when the box is on top, press the button. But if the box is on bottom, don't press the button. Okay, so there's two measures right there. The box is on top, they're paying attention, they press the button. We consider that a measure of focused attention. Right? You got to be focused to know when to press the button. The box is on bottom. You shouldn't press the button. But if you do anyway, we consider that poor impulse control. The third measure is how long it takes for the box to flash up there until you press the button, so the reaction time. And the fourth measure is looking at how well you do in the first half of the test compared to the second half of the test, how well you do in the first quarter compared to the second quarter, compared to the third quarter, compared to the fourth quarter. We call that consistency of attention, which is just another way of saying sustained attention, the ability to get focused and stay focused. Well, here's a 13-year-old that we tested with the TOVA, and she came back really clearly ADHD. Okay, and this will be a graph, a bar graph, with 100 as average. Like an IQ, it's a standard score, but 100 is average. Okay, so that's what we want to see, is around 100. Okay. She came back, her scores were 25, 35, 79, and 43. Okay, imagine an IQ of 25, 35, 79, or 43. Be really, really impaired. Okay? Came back 2 weeks later. I talked to the physician. The physician put her on a stimulant. Came back 2 weeks later. And when I test again, I like to test 90 minutes after they've taken their meds, because that's when it's up and working and it's pretty full force. Came back 2 weeks later. The scores were 58, 83, 88, and 64. Really a lot better, but still not near 100. So I called the physician and said, well, this is the result. They said, well, let's try a different dose. So they increased the dose. Here she is 2 weeks later. 107, 96, 107, 104. Okay, so I'm just going to show you the bar graphs. You can see the bar graphs are pretty clear. The blue is the first testing, the red is the second. Okay. Another one I use is called the Quotient. The Quotient was developed at McLean Hospital and was the first ADHD assessment. McLean Hospital is a teaching hospital at Harvard Medical School. So it was developed by some Harvard neurologists. And I don't know, we have some physicians in the room. Maybe y'all will understand this and can explain this to me. But I'm a psychologist, and I'm like, why did you do this? They took the quotient. They said, we got to get this cleared by the Food and Drug Administration. And I'm like, it's not a food, and it's not a drug. Why do you need it cleared by the FDA? But apparently physicians like that. If it's cleared by the FDA, then it's A-OK. So these Harvard neurologists got it cleared by the FDA. But it's very similar to the quotient, the TOVA. The thing I like about it is we have this little band where we put a dot right here on their head, and it has a laser tracker that will follow the movement of the head. So we actually have an objective way of assessing hyperactivity, which is really cool. Now, one of the things, you're going to have somebody else talk about medication in just a minute, but I'm going to say one thing about the stimulants, and I think this is amazing. I already told you that for decades there have been studies where they've looked at the MRIs and CAT scans of people who have ADHD versus people who do not. And there's clear differences in the frontal lobes. Well, according to Barkley in his handbook on ADHD, which was published in 2015, I read this and I just about fell out of my chair. And I personally think this is worthy of a Nobel Prize. I think this finding is so incredible that it deserves a Nobel Prize. So let me tell you what the finding is. He says as of 29 studies to date, well, let me tell you what they did and then I'll read the quote. Instead of doing ADHD versus non-ADHD, he had three groups. ADHD who never had stimulant medication, ADHD people who've been on stimulant medication for a number of years, versus never had ADHD. He found significant differences. And this is what he wrote. This is on page 367 in his handbook. 29 studies to date have noted that brain development in children treated with stimulant medication is closer to that of the controls who do not have ADHD than the children with ADHD and never treated with stimulants. So people are worried, oh my goodness, what's the long-term consequences of being on stimulant medication for decades? Well, I'll tell you, it makes the brain more normal. Isn't that incredible? And we've got MRI and CAT scans to prove it. I think that is fascinating. So Barkley also says treating ADHD medication may result in greater normalization of brain development, known as a neuroprotective effect. That is, than if the medications had never been used. This makes some sense given that clinically effective dosage of stimulants increase brain activity in the very regions that have been found to be underactive in the various functional neuroimaging studies. So basically he's saying it's like exercise. It's like since my back surgery, my legs have gotten weak. Why? Because I haven't been, I can't do physical therapy yet. I can't wait to get to where I can do physical therapy and exercise those muscles. Well, it's the same thing with the frontal lobes. If they're just sitting there and they're underactivated, they're not being exercised. The stimulants activate or exercise the frontal lobes. I think that's fascinating. The medication actually has a neuroprotective function. Okay. Good, I have 5 whole minutes left. A couple of things about, no, I'm doing good. I appreciate it. What I tell parents, so medication we're going to talk about, in a few minutes. But what I tell parents is that in addition to the medication, there are 4 things that you need in dealing with an ADHD child. Okay, for that matter, an ADHD adult. And the 4 things are structure, routine, and consistency. I said 4, didn't I? Well, what's the 4th? Calm. Calm structure, calm routine, calm consistency. And what I tell parents is that getting emotional with an ADHD child is like trying to put out a fire by pouring gasoline on top of the fire. It just makes it worse. So a lot of the therapy I do with children who have ADHD is really parent training, is really teaching the parents how to implement the structure, routine, and consistency in the child's life. Now, this becomes challenging when I know that there's a 57% chance that one of those parents has ADHD themselves. And so a lot of times, I mean, I've been doing evaluations now too many years, well over 30 years, I'll say that. And I can't tell you how many times I give the feedback sessions to the parents about their child. More often than not, it's the wife kind of elbowing the husband, saying, "He's talking about you." You know? And there's been plenty of times when I have evaluated the father, and sure enough, the father has ADHD as well. One of the things I have here, one of the things I do for particularly if they're 12 and under, is I have a particular form of timeout that I teach the parents. But it takes me 3 weeks to teach timeout. And the reason it takes me 3 weeks is I want the parents to get to a level of precision in implementing it. I want them to do it very well. I don't want them to cut corners. So I have a flow chart, and I have them memorize the flow chart. And when they can say it to me perfectly, and that takes a week or two, then they practice by sending me to timeout. And when they think they're getting good, I throw in all the monkey wrenches, okay? And I want them to have precision and excellence in knowing how to do it correctly. The 4th week, I bring the kids in, and I teach it to the kids, and I practice with the kids, and the father practices with the kids, and the mother practices with the kids, and step-parents will practice with the kids. And then they go home and then they do it. And what I tell people is this is like parachuting lessons. After one parachuting lesson, the instructor doesn't say, "Go home and try this on your own and let me know how it goes." The parachute instructor says, "Don't you dare do this until I certify you. I know you can do it well." So sometimes it takes me longer than 3 weeks to teach it to the parents. Okay. There's a book out which I like called Science and Pseudoscience in Clinical Psychology, 2nd edition. I like the pseudoscience part because there's a bunch of junk science out there that masquerades as mental health. And so one of the things they do is they talked about empirically supported treatments and unsupported treatments. Well, empirically supported treatments are stimulants and behavior therapy and a combination thereof. We know that a combination of stimulants plus behavior therapy is the best treatment for ADHD with children and adolescents. We know that some of the cognitive behavioral treatments for adults are very good. And you know what most of the cognitive behavioral treatments for adults are? It boils down to 2 things. I mean, there are programs that are like 12 sessions long. Most of the programs focus on 2 things: time management and just organization. So it teaches, you spend 3 weeks teaching people how to use a calendar or a planner, okay? And you have them write their to-do list down on their planner. Now this seems mundane, but when ADHD adults don't do that, their life is in disarray. And when they start doing it, their lives get better. Unsupported treatments, in other words, don't believe it. It's junk science if you hear that restrictions of sugars and sweeteners help with ADHD. It doesn't. Now, should you just give lots of sweeteners and sugars to kids in general? Well, of course not. You want them to eat healthy. You don't want to have junk. But it doesn't treat the core deficits of ADHD. It has no impact whatsoever on the core deficits of ADHD. Sensory integration interventions, which are done by 90% of occupational therapists, no research at all that it does anything for ADHD. And here is a total and complete waste of time: play therapy. or for that matter, individual therapy with an ADHD child. Are you kidding me? That is just burn their money, because that is a waste, and there's no data that would say it does anything at all. What is far more effective is family therapy, teaching the parents how to be parents and how to implement the structure, routine, consistency in the home. Okay, well, I could go on for a while, but we're going to let my psychiatrist colleague talk about the medication.